ourselves start the meeting on time. Yeah, good. So if you join me in the pledge to allegiance. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome, welcome. Item number 2 is public comment. Either of you want to have public comment before we go on?
No?
Okay, we'll continue then. Item number 3, approval of the consent agenda. Here a motion to approve.
I so move we approve. I so second.
Moved and seconded. All those in favor say aye.
Aye.
Approved. Cheryl, July financial report.
It's slow. My goodness. Thank you. Alrighty, so July 2019 is the first month of fiscal 2020. We had a pretty busy month in the hospital. We saw 375 patients. Last year at this time we only saw 285. That's a huge increase. Our average for each month last year was 326. So really, we had a big month right there. We had pretty good numbers almost everywhere except surgery. In ancillary services, we also had another really big month. Not really looking at July of last year as much as I am looking at the prior year's average numbers. So 26 to 32, 604 to 688, 916. These are big, big numbers. Home health is pretty average busy. The health clinic was pretty darn busy with 1,075. The only places where we saw a little bit of a slowdown was the alternative health clinic and the wellness clinic. With Alturas, I mean, a doctor takes a day off or 2 days off and you're going to see that decline. So I'm not very worried about that. This is kind of an anomaly here where they saw 990 patients last July, but this July really saw 803. But our average is 782, so this is really a fairly average number. Our length of our daily census, no surprise, swing beds, but our length of stay got a little bit longer. So aside from the fact that it was a busy month, there's nothing really noteworthy. Our monthly gross charges, patient charges were $3,545 million, so that's right up there. Last year's average month was $3.3 million, just about, so that's a good number. Not surprising based on our productivity that you saw in the first slide. Our collections on accounts receivable, this is the one slide where we're able to report the next month, because August obviously is over and we're done collecting cash in August, but we had a good month in July, $2.6 million.
That's how much we collected?
Collected, put in the bank, on patient AR, not including other things. So if it wasn't on patient AR, it's not here. So no tax money and no donation. So, anyhow, and then in August, we're at right about 2.3 million. So pretty good. Our last year average was really close to $2 million a month. So, not bad. Our days in AR were 71 at the end of July. They were 68 at the end of August. And they are 67 as of today. So this is where we started last January and just keep going down. So this is also a very good number. And this might change.
Yes.
Yes, it would be really nice to start as low as possible when we move to Cerner, because we know that's going to be a big.
What is the estimate of when that new system will be?
We to April 20th. So yes, we are certainly focused on this, we're working hard on it, and yes, it's going to continue until forever. Our days cash on hand dropped to 59 from 68. Now, I'm kind of not to realize that because we deposited a lot of money, so what the heck? So what drives this number is, first of all, the last 12 months' expenses. So we're dropping off lower months with expenses and adding on the higher months. So we've had a high expense level for 12 months, so that's holding.
Is that just construction cost or?
Yes, moving, construction, all of the above. And then even though our collections were good, our cash didn't go up quite a bit because June was so low. So
What was low?
June's collections was very low, oddly low, but normally June is low, so it was quite. Okay. Our profit and loss statement, usually I have 2 slides for this, but since our current and year-to-date is the same number, we're not going to look at that separately. So what I've got here is, this is our actual month of July. This is what it looked like in July of last year. This is what we budgeted, and this is the variance between budget and actual. So looking at total revenue, we budgeted, or we had an actual revenue, net revenue of $2.66 million last year, so we had $300,000 more than we had last July, and we are $232,000 net operating revenue below budget. We budgeted for almost 2.9. Our salaries are $71,000 below budget, or above last year, and below budget $157,000. This is mostly because we haven't hired doctors, or we have some LCSWs and a doctor and a surgeon that we're planning on. I'm sorry, licensed clinical social worker, another social worker. Total expenses were $2.6 million, which was $139,000 more than last year at this time, and $126,000 less than budget. The net loss for the month was $11,000, quite a bit better than last year at this time, but below budget by $122,000. And then our balance sheet, really very little change from last month, and the change year over year has a lot. I mean, our cash is down a little, our AR is up a little, mainly because we've got more revenue driving. We've got more debt because we've been borrowing on the loan. We've got more assets because we added buildings. So really nothing different than I said last month, year over year. All right, any questions on Lake Health financials? Okay, so we're taking over. Okay, yes, ma'am. Charlie, you're doing the disposal of surplus policy in Salvador.
So we talk a little bit about, you got to deal with, Joan, since you've heard this before. So as a special district, or as a district organization, anytime we have any of the assets, they are considered public property. And so anytime we are going to find something that we no longer need to use, for whatever reason, then we have a couple of requirements on how we dispose of those assets. It could be a piece of equipment, it could be supplies, it could be desks. You may have seen in the past, we've had spring garage sale sort of thing, where we put all sorts of stuff out and let the public come and bid on it or buy it. Sometimes we put price on it, depends on. Especially we did a lot of that when we did the new hospital construction. We had old doors that we were changing, old desks that we no longer use. So all that is considered surplus. So as a district, it is required that couple things have to happen. Number one, the board of directors has to describe it as surplus. So we provide you with the information about something, and you have to deem it surplus. From that point, we have a policy that describes how we dispose of that. We're making a little bit of a change in our policy. So what our policy has said in the past is one, we would either, there are items like door frames or doors that takes a special person that wants to buy them, or some old cabinet that we had been built in and we no longer can use. The other items that were typical that we have disposed of have been vehicles. And we have donated those vehicles to the Lions Club. And then the Lions Club has auctioned them off. Okay? We did that for a couple of reasons. Number one, it benefited the community through the auction process. And number two, under advice of counsel, we didn't want to be in a position of selling a vehicle, have the buyer become disgruntled, come back to the hospital for claiming that we sold them a lemon. Well, we donated it, and they bought it from the Lions Club, and really couldn't come back to the Lions Club. So that was the principal nature of how we dispose of surplus items. We have now something that we would like to have you deem surplus. That doesn't quite fit either of those categories. And that is the old salad bar. So the volunteers bought us with their proceeds a new salad bar. And we have the old salad bar. We don't have a need for it. But there have been some people, organizations within the community that have expressed interest in buying it. We don't know how to set the pricing on it. And we're not going to just put it out on the sidewalk and let anybody buy it. So we're going to recommend that we're in the process of establishing a policy that would say we set a price, do either a closed bid or some way, fair way of allowing the public to buy it. Probably the biggest concern that special districts want to address is the fear that we would give employees first option to buy things, and that would be unfair to the general public. So as a public entity, we have to let all of our public have access to buying anything that you deem surplus. Okay? So what I'm asking for tonight is, I'm asking to approve, I think we sent out this policy. I don't know if anybody saw it or didn't see it. It's a pretty straightforward policy. We are revising a little bit of the use, because the other policy that combined with this said, or described the use of tools and equipment, so that employees couldn't make use of tools and equipment that are part of the assets of the district, take them home, use them, and bring them back. That's what is occurring many years ago. We've addressed that. We don't have that happening. So we're separating out policies. So I would like to request, number one, that you approve our disposal of property, surplus property policy.
Ken, I know that you had forwarded some questions. Did you get those answered satisfactorily?
Jim responded. One question was did we have any ORSs that gave guidance? And apparently not.
They're not, no.
And the second,
What?
Oregon revised statutes, not the taxing district. Could it come from the county? They do, so I was curious. The other one was that second paragraph read kind of odd to me. And about surplus into agencies created to do surplus. I mean, it just, maybe I read it wrong 5 times.
We have the option of either like the donations, or as a municipal government, we can, if we have a large items that we want to surplus, we can contact the state, their surplus inventory department, and actually, kind of like the federal government has as well, and send it to that type of
Okay, that answers that.
auction. There we go.
Yeah, I'm familiar with that.
Yeah.
And so for those of you that don't know, the state process is what the county government or county entities want to dispose of their surplus properties, old vehicles, stuff that they're no longer using, they can sell it on their own or put it into a state repository and anybody can bid on it. And again, it's allowing the public to have as much access fairly of those items bought with, supported by state or tax dollars.
And the third curiosity question I had was that last statement about, I had to go back and look at it, but there was no guidelines on determining what, it was just a general statement, which is fine, but I've got a little more tightness.
So, do you want to look at the policy?
Yeah.
Can't remember.
We didn't print out a lot of copies.
Yeah, it was on what we were declaring surplus.
That's valid.
Yeah, the last one, surplus property determined to be of insufficient value to merit auction or donation, may be disposed of in any appropriate manner, which I agree. It's just a general statement. Do we have any guidelines to determine insufficient?
We really don't. And sometimes it's either dumpster or declared surplus. Some of the items, really, nobody would. We don't have anybody that likes to repair old air conditioners. We have to dispose of those. And we can't really deem that as surplus and let somebody try and buy those. If somebody expressed interest in something like that, then we might be able to say, okay, we could declare it surplus and they could acquire it. It's a fine line.
Yeah. It's a general statement, and I was just thinking of.
Well, and the legal counsel at SDIO said, and the reason they have the policy is fairly minimal is to allow for us to be able to work through that. Exactly, because especially certain items, I mean, we declare them surplus and they go. He says, when you get more into the weeds, he says, then you're restricted yourself so significantly.
Yeah, it's plus and minus one way or the other.
Exactly.
Right.
Anyway, I had curiosity on it, and I'm okay with it.
Serene or John, any other questions regarding the surplus property policy? If not, then I'd entertain a motion to approve.
I'll also make the motion.
Mylan, second? Seconded. All those in favor, signify by saying aye. Aye.
Thank you. The second item is I would like to have you declare the South Bar item to be of surplus. And then once you do that, then we would go about the process of allowing the public to know, so we would have to promote that information and give the public an opportunity to either look at it and then we'll try to set some value. It's really hard to determine because it's probably 15 years old. It's hard to say what we do.
Yes.
Yes.
I so move that we surplus the old solid barn.
Thank you.
Here a second?
I'll second.
Okay. Been moved and seconded that we declare the old salad bar surplus. All those in favor signify by saying aye.
Aye.
Aye. Motion carried. Item number 5, Goose Lake Medical Services. Sheriff.
Which includes Lakeview Gardens and Lakeview Medical Supply. So here's Lakeview resident days was 465 in long-term care, 403 in assisted living. So that's net collective year-over-year increase of 100 days. This is the this is long-term care revenue. That revenue is down from prior years because we opened the L. Last year, we were just getting started, so this year is much better than last year. Total for both of them, the gross charges was $194,000, pretty close to road running average. The net revenue is $194,000. Last year, this time was $189,000. Our loss for the month was $138,000. I would like to see that be about $50,000 less, so that's kind of my goal, and I'm shooting for. Last year we lost $147,000. We have a balance sheet here. There really are no changes. There really aren't. I'm just adding it here so that we see that it's not changing.
So are the allocated expenses, the expenses are charged back to the hospital?
Yes, like it's the amount that we would charge them for doing their billing and doing all their accounting and there's a long list of things that,
Housekeeping, food service, maintenance, those kinds of things.
yeah.
Sherry,
Water.
I mentioned you like to get a 50,000 below the 138. How would that evolve?
Because historically, we have for years and years lost about $1 million a year on the long-term program. That's just kind of been a comfortable place for us. If, we've got the tax dollars coming in and the hospital can generate, so it could be higher if the hospital starts generating a higher cash flow or a higher profit. But just historically, that's been a comfortable place. So I would like, I would like to see that loss reduced.
A big component of that has been the contract labor. Those are the
Yeah.
agency nurses. As an example, we just finished 7 people finishing the CNA class. Once they take their test next week, if they pass, hopefully all of them will, then they can, after about several weeks, start replacing those agency staff. And that cost really gets reduced with replacing employee people from agencies. So, hopefully. And we'll be having another class starting a couple of weeks ago. And we'll simply advertising, get them.
It'd be good to have all of our houses full as well.
Also, on the CNAs, over the past, what's been the trend over the years as far as recruiting new CNAs? Has it been up and down or consistent?
It's a constant changing workforce. We have some people that have worked for us for a long time. We have some people that have worked for us for a short time. And then it fluctuates constantly. One of the things that has impacted the CNA workforce is the RN program through Klamath Community College. Because a lot of the qualifications, it's not required, but it helps them to get experience working as a CNA. So if they become a CNA, they work for a little bit doing that, and then apply to get into Klamath Community College, the RN program. It's a great way of improving their situation. So we see more of that transition, but we also see a lot of the younger people that would start in the CNA and stay aren't staying as much. They're moving, they may not like the job. It's hard work.
And they need daycare. And they need daycare.
Yes.
Lake Health Medical Supply, the DME business. So last month, I reported a loss of $4,000. This month, I'm reporting a loss of $3,000. Only last month was updated to a profit of $6,000. So we got a brand new billing system in starting last month. So we're a little behind on getting that all sorted out and going, which is totally normal. So I just wanted to mention that, yes, we're showing a loss here. I'm not sure if that's gonna move or not, based on, and I would think that in the next month or two, we should be getting close to getting better at using the system and having it up to date and all of that, but not really a shocker. So
So it seems that for $21,000 gross revenue this year, how high they are, is that what the insurance companies are waiting for?
yeah,
Or they-
it almost always, or people who are making payments.
Okay.
And that's it.
Thanks, Sheila.
Steve,
Yeah.
you're here and you're ready for it.
Yeah. I just have some traditional handouts for you guys, so you guys can. There.
Yep. What do you do?
I'm the IT director and information security officer for the hospital here. Sorry, didn't introduce myself. And I'm also the project manager for the Cerner implementation. So. So I'll just kind of go through this. This is basically a newsletter that my team, which the project management team, develops, and we're going to be sending this out, I believe, monthly to all employees. And it kind of is a nice little update, kind of gives it a little highlight. So I'm just going to go through this and kind of answer some questions as we go along. So as you know, Cerner Community Works is the system that we're going to be using to replace multiple electronic health records here at Lake Health District, including CPS IT systems, point-click care, Credible, eventually Credible, and I'm missing one. So basically replacing a bunch of our EHRs. One thing that we did do, and this is fund adoption, so basically, as you guys may or may not know, probably do know, that we took quite a while to determine which system to use, and it was over 18 months of vetting out various systems such as Epic and Cerner and other systems that we looked at. But we came with Cerner, and Cerner has, they give us a lot of good recommendations. And one thing that we're doing to make this an easier adoption for people is we're implementing a Cerner theme, and basically the theme is going to be a Disney theme, which everybody voted on. Like people who did voted on Disney. We had several options.
The whole organization.
The whole organization. So every department gets to choose, a different type of Disney type of thing they want to use. If they choose to do that to help people engage into the adoption of change that's going to occur, which is going to be a lot of workflow changes coming in the next.
So is this going to affect every department, including the medical doctor's offices?
Yes, every single department is going to be affected. So basically, this newsletter, we have little abbreviations there to kind of start educating people on some things, but I'll go right down to the project event timeline, just kind of going through that. The first big thing that we're going to be doing, as of next week, we're sending the core project management team over to Kansas City. And in that project management team is, of course, me, the project manager. We've got Cheryl Cornwell is the executive director. We got Susan Poitier, she's the revenue cycle lead. We've got Lisa Herndon, who's clinical informatics, but she's going to be the education coordinator. And she's the one who created this newsletter for me and sent it out. And then we have Diane Trechter, who's also on my lead informatics person, who is going to be our clinical lead, who is very knowledgeable in clinical workflows. So that's the core project management team that's going to CERN next week, and we'll be learning quite a few things, with regard to, what to expect, expectations, the project, core fundamental things that we need to learn to be a successful project. And CERN's done this quite a few times, over 200 critical access hospitals throughout the nation. They've done so they got the system down pretty good. So we're going with what they're recommending and trying to vet out what we can and do what they're recommending in order to be successful as much as we can.
When you guys were vetting the system, did you visit any hospitals that have recently implemented?
Recently implemented? Yeah, I think so. It was, which ones did we, recently implemented?
Well, recent that one, but, yeah.
It was, we visited.
We went to Astoria, so
Yeah,
they,
that's true.
so some of us went
Yeah.
to Astoria, and part of that reason was because they had been on the same system we are on now, and they converted to Cerner, so we got to learn. And that was a smaller group, nursing and physical therapy went to Astoria, but we looked at a hospital outside of Kansas City in Kansas. So.
Yeah, we vetted out. We actually went to Epic Hospitals. We went to Burns and saw how they were using the system. Give everybody
But that's a different system.
Yeah, absolutely. And that was part of our vetting process. And that's why it took quite a while to make a decision, overall. But yes, we did visit a lot of different hospitals and talked to a lot of different people. So right now, I'm in the thralls of data collection, workbook calls, and those are all ongoing. So basically, in order to be successful in the project, we have to have a lot of calls with a lot of different departmental managers and a lot of different analysts from Cerner in order to gather what kind of data we need, from either lab, radiology, supply chain, pharmacy, health information management, patient accounting, you name it. We're doing a lot of data collection calls, and it's really core to the fundamental success of the project. And they can't stress enough that the proper data collection that's occurring right now in order to make sure that we're successful.
Are they putting any staff here during the implementation?
Yes. There'll be basically an army of Cerner employees here, quite a few actually, during go live and throughout. As I go through this timeline here, there's lots of, the only ones that are in Kansas City are the boot camp and the train the trainer, which is about midway and a half, which we're going, lots of staff are going to be going to Kansas City to get some training, super user training, to get more in-depth knowledge of the system in order to be able to support their departments. And as part of their model of success with regard to super user training. All these other events that you see here are going to occur here at Lake Health District. So they're going to be coming here and doing a lot of integration testing, both financial and clinical. As a matter of fact, they're doing scheduled for 3 financial testing and 3 clinical testing. We just had our first physician experience call with our CMIO, which is Chief Medical Information Officer. He attended, which is Dr. Foster, who's representing that role for the hospital. And we're learning how the physicians are going to be trained, when they're going to be trained, how many hours are dedicated during a certain week, and getting all that scheduled, and getting ready to go, making sure that the proper people are in the calls that they need to be in order to be, to make sure it's going to be successful. And my job as a PM is to make sure all the resources there are available, make sure that if there are any issues with regard to scheduling a call or having the right people in the call and getting the right answers to Cerner is my job, and getting the right people in there and coordinating that is important as a PM. Going down real quick, we've got, if you can go down there, learning and adoption workshops. We've got those. We have those scheduled in October. Workflow and integration is going to be a big deal for us too, because they're going to get, after they get all of our data, they're going to go through and we're going to learn all of our workflows. How our existing workflows, what the present workflows are, and what their workflows are, and then integrating and changing what we can and making things work and integrate. So there's a big process with regard to workflow and integration in Cerner's process. So that's that really key date there too. Another thing that we're doing that is really important is the charge master. It really affects every single department, and we're already working on that right now. And that there's due dates that they give us, and they hold us. We need this. They get meetings are happening all the time to make sure they happen. Susan's involved with that as well, and several amongst other people that are involved with making sure the charge master is correct and up to date.
And that's the codes that we build to get it paid right.
Yeah, basically making sure everything's all in the same, because we're going from several systems to one, and it's kind of a big deal to make sure that everything's correct, to be successful there. So I talked about the train the trainer, another big event over in Kansas City. Several more people are going over there. Going down, I did talk about the integration and testing. It's going to happen after the new year, between basically around the beginning of January to mid-March, as all those clinical and financial testings are going to occur. That's a pretty important key dates that we're going to have there. And then we're going to have, towards the, right before, our go-live date is scheduled for April 13th. And prior to that, they have scheduled physician education and training. And so it's really key for the physicians to get their training just before they go live, to make sure that they're ready to go. So they'll be here. They'll be here on the 30th of March and the 4th, or the 6th of April, 2 weeks, doing the physician end user training, and making sure the physicians are getting the proper education they need in order to be successful, which is the total bread and butter key, you know, to make sure that they absolutely know how to use the system, you know, in every way, shape, or form. And after the go live, and after the training, after the go live, it's basically a week with probably at least 20 Cerner people. I don't know the exact number, but a lot of people will be here during that time, representing all the different departments in the hospital, because we're going, it's called Big Bang Theory, basically everything's going at once, you know. And so we're moving over to Cerner during that 1 week, everything's going. And then they have, after that, they have scheduled periodic health checks to make sure that we're optimizing and using the systems the way we're supposed to be using them. So right now, that's kind of a big overview. A lot of these, we have it, some people, as the project manager, they're getting a hold of me right now and starting to schedule these calls. Some of these, you know, they're not quite ready for that phase in it yet, but it's coming and we're working really hard. A lot of people are working really hard on this right now. Several departmental managers are spending a lot of time with data collection right now, and so it's a big team effort that's occurring right now here at Lake Health District, and so it's all hands on deck right now. So we're in the throes of ramping up.
Sure, we're going to make sure we get our cash.
Yes, we do.
Because it was sure. Well, it's easy that you can have hiccups in billing, it's going to really affect our cash flow.
One of the things that we are going to institute, for example, is no vacations at all. No time off, unless somebody is dying or is really sick. We want everybody here. This is such a big deal.
That's fine with you guys.
Any questions from the board for Steve? A lot of work for you already and yet to be. Appreciate that you're on top of that. Good. Thanks for coming.
Thank you. Some of the other things that Stephen's working on included in this is how do we deal with our legacy systems, current systems that we're using? What is the process to begin phasing that out? What do we do about the records that we have, some of the paper records, how do we scan them, where do we put them, all those kinds of things. So it's a very multi-phased program.
And expensive.
Very expensive. Yes.
Should save us money in the longer scale.
Yeah. This is mission critical. Yeah, to bring an organization to the stage.
Great. Thank you for your time.
Thank you. Construction update, EMS building / additional cost. Sorry.
So, can I use the little mouse to look on something here and see if I can make it work? So one of the things that we are faced with is where do we stand with this project? And when we originally started our discussion, we had our kinsman bid at $1,225,000. Yeah, to point. Thanks. Oops, that wasn't what I meant to do.
Yes,
No, I
you
hit
did.
the wrong thing.
Okay, so the pointer is literally the
Center
center,
button?
yeah, the little yellow button.
So $1,225,000 is the bid that we have from Kinsman to build the building. About $10,000, that's a rough estimate, but pretty reasonable, for plan review, permits, that kind of thing. We know that our contract with Anderson Engineering is $55,000, and we estimated the cost to connect to the power plant. That estimate just came in more accurate just a couple days ago, is that correct?
Yeah, originally, if you remember last time, we had a $20,000 figure in there. We met with the power company on the 27th, reduced that down to 8. We're gonna do things a little different coming off the poles out there. So So that was a help.
So what we now are faced with, and we realized this when we submitted our plans to the state, Darrell was confident that by having essentially two buildings, one where we put the vehicles, the other where we put people, that it wouldn't be required to have a sprinkler system. That's the reason we set it up that way. Unfortunately, the county building inspector had a different view and said, no, you have to have sprinklers. And they changed some of the window structure on the second floor. We did not have at the last board meeting cost estimates. We now have $74,325 estimate, or bid from Kinsman to put that in. We did not have at that time, last month, what Basin Telecom does. Basin Telecom is the company that connects all of our telephones, all of our badging systems, all of our fire suppression systems. So if we put in a sprinkler system, what we want to have is if there is a fire and the sprinkler goes off, it enunciates to the main hospital enunciation system. Notifies the outside agency, that notifies the fire department, notifies our staff. It means that every building on our campus is on the same system. And that is really important going forward. We have an estimate for additional engineering costs to design out the sprinklers and to do some work on a backup generator. We have here an estimate for, and I've separated into what we have to do and a possible delay in this. We purchased several years ago lights and poles for the back, the south side where employee parking is. We haven't put them in because we didn't know exactly if we were going to build the ambulance building. We didn't know exactly what we were going to connect. Now it makes sense to do. How many poles do we have, Darrell?
6.
So 6 poles. That, we don't have to put those lighting in. It is dark there, and it is concerning for employees that work at night. We will have more traffic by having the ambulance approval, the emergency group there. So while it may not be required, it's pretty darn highly recommended. We need to do it at some point in time. Then we talked about the need for a backup generator. Now there is no, in code, there is no requirement that we put up a backup generator. We talked about this at the last meeting. We looked at the possibility of, or what is the purpose of the backup generator? If the power goes out, and it does, will the ambulance crew be able to open the doors? Will they be able to turn on the lights and function? Most of the doors, they'll be able to lift them manually, but it would be nice to be on a backup generator so they can deal with that. We had one estimate of $35,000. It's come in at, we're not absolutely positive, but pretty darn close to $73,000.
Do we have capacity with our existing generators to tap into that?
We do have capacity. We asked the engineering firm that built, and architectural firm that built the new hospital and remodeled this component of it. And what they said was, number one, the cost to do the work, to do the engineering work, would cost about what the cost of a new generator. And number two, and the connections. But they recommended to have an independent system. Part of it is because when you go into a hospital system, then you have all sorts of additional approvals from other agencies that look at this. If it's a standalone, it's a more, it's a simpler installation process. Is that correct, Darrell? Have I got anything wrong on that?
It's simpler. We did get an updated generator cost. I got another one about 6 o'clock here. So that number has went down to 70. That generator is a little bit large. It has quite a bit of future capacity in it. We could maybe go with a smaller generator, save a little money. But,
Is it propane or?
it's diesel. The reason we went with diesel is to not have the propane tank and all that other thing involved. So the quote is for a diesel generator right now.
So what that says, when you take all these unexpected costs, that takes the price from $1 million, essentially $298,000. When you add in the extra costs over and above the Kinsman construction, to $1.5 million. Now, we have, this is our funding fund. We have a commitment from the ambulance group of $250,000. We have a cash donation from former associate of Chuck Kelly of $500,000. That is sitting specifically in our restricted fund for this purpose. We finally got from the bank and from the Detroit Construction the final number on what our available borrowing is. It's a little bit less than we expected, about $80,000 less from what we reported last month. But that brings us to a total of $1,071,000 of borrowing capacity. I have not gotten the answer from the bank and from the bond attorneys on the $321,000 if the project is not completed by the end of this year. You recall, that was an issue. The bank doesn't seem to be too worried. The bond attorneys can't quite yet decide whether they need to give us opinion or not. But we can certainly borrow the money.
We're still $500,000 short.
We're still $500,000 short. That's correct. If we postponed these items for $91,000, it's $434,000 short. Now, how do we finish this project? One thing that we can do is we can postpone some of the other items that we have planned on spending for the hospital to make this happen. We could certainly ask the ambulance group if they would put up more money, but here's what they're already committed to doing because they were not part of the construction. Number one, their 911 alarm connection. They're paying for that. That's not part of our cost. They have volunteered to paint the interior portion where the team will be not the car side or vehicle side, but the other side. They would be providing the washing machine for their protective clothing. Now, that's not just a run-of-the-mill that you pick up at Maytag. That's, if I'm not mistaken, Daniel, that's a roughly $30,000 washing machine.
That'll be correct.
So it's not an insignificant amount. And while if we, as we go through with base and telecom, with this estimate, that puts the connections to the wall. That does not include telephones, computers, furniture. So the ambulance group is, so that is their portion.
I know this was all approved previous before we got from my anyway. Do we make any revenue off the ambulance? I mean, is Lake District Hospital?
The only revenue we can get from this venture is the rent that we would charge the ambulance group for using the space.
But if the ambulance goes out, it's charged to the insurance company. It does not come to Lake District.
No, it goes to the ambulance group. They would be renting the space. We're building it for them to use.
They do their own billing,
They do their own billing.
they supply their own staff.
So we aren't employing these people.
They are a nonprofit, fully volunteer, well, virtually fully volunteer organization. And they have been providing service to this community for 75 years at least.
They formed in the 60s, I think.
Oh, 60s?
Somewhere
So,
around there.
for a long time. And provide a very credible service.
How do you come up with the rental rate? Sorry.
So, the bond council was very specific when we borrowed the money to build this and the other two projects. Because this money that we borrowed to get where we are, because it was $14 million. A portion of it was used to build long-term care and assisted living. A portion of it was used to build the medical offices. The requirement is we could, because the cost of the loans are specifically geared for public entity organizations like us, the interest rates are better than if we were just a general nonprofit. So we cannot give the benefit of that financing to any nonprofit organization. They were very concerned when we started this process, and the bank and the bond attorneys, the bank wasn't here, it's the bond attorneys, said, in order to do this correctly, you cannot have a lease agreement that is for the life of the building. That would be essentially giving them the building. So we can give them a lease agreement that is less than the life of the building. Rough life is 30 years, so we couldn't do it for that length of time. Second thing is we could not provide it at a discount, so we have to be able to base it on what our construction cost is. That's how we establish the rate.
So, for instance, if this costs 1.5 million, and we could choose to have a 25-year life, we can spread that, so 1.5 million over 25 years.
Yes, and then we would have an agreement with the ambulance group to, say, be a 3-year agreement with 10 or 8 renewals. So it's not for the life of the building, but there's nothing wrong with having what's called an evergreen clause. So we could say, all right, we'll make it 5 years and do it for 5-year lease agreement with 5 renewals. We'd probably do it less so that we wouldn't run the risk that we're giving it for the life of the building. We might say 5-year lease with 2 renewals. That's 15 years. And the likelihood that we're going to use the building for anything other than the ambulance group is pretty low.
Then there's no chance of increasing that financing availability. I mean, we can't go back and say we need another 300.
We have not approached the bank on that. That would require, I mean, I certainly could ask that, that would require the board to authorize us to do that. And I don't know what the bank's position would be. I thought about asking that before it came to the board today, but we can certainly do that.
Bond financing would probably take a really long time. We probably could get financing a different avenue sooner if we wanted to, I would think. But
There are lots and lots of entities that would be happy to lease this money provided. We'd have to have approval from the bank for that short time period, for that limited dollar amount. Right now, they have the right, if we, say, for example, wanted to buy another CT scan, ours went out. We'd have to have their approval to get the financing, say, from Siemens or GE, and they provide really good financing.
Well, we have to find a solution to the half-finished building, right? It's no value anyway.
Yeah, and I just say to the new members of the board, we were eminent about not exceeding a certain dollar amount, and it has happened. So that was then, and this is now, but we were very, very adamant, I thought, that this is not going to see this level right from day one.
Are there any grants through the state that is possible?
We have looked at some grants. Number one, the grants predominantly are made specifically to a disaster unit or an ambulance group. And it's often for equipment or training, not for building a building. We have not found any way to find grants for it. There are monies available, and I believe the disaster unit is working hard to try and find grants and other ways of coming up with money. But they do that on a regular basis for their ongoing operation.
Daniel, do you have any comments you would like to make or questions for the board?
I know one thing on the sprinkler system, so I talked to Darryl a lot about it. And I reached out to a lot of my folks I know from the fire marshal's office in Salem and Klamath. And they made phone calls to their building folks and they interpreted the sprinkler code the same way Darryl did. It's one individual that reads it in the footnote saying that's required. Everyone else says we shouldn't have had a sprinkler, anything except for maybe the residential area or the sleeping area. So that threw us for, not quite the loop for the 75 grand. This whole project started in 2008 when we went around our room and we had 30 members saying, how do we get you to make more rooms? And they says, if we have a place to make more runs. They said if we have a place to throw our bedrolls and a place to stay the night, hang out when we bring our kids to town, we can make more runs. This was some of the Adel Plush folks. So we started this in 08. It kind of died out. We brought it back up. And we're making some progress now. So it's definitely a need for the community. Whether 10 years from now, whoever's running our units is still going to need this facility. So.
Charlie, what's the bay capacity of number of ambulances that have been in, and how many would there be?
4 units.
Four ambulance units could fit?
What about community?
Fundraising.
Well, I'm thinking more like groups that are coming into the community that are new.
Red Rocks.
Red Rock, all the marijuana stuff, also the solar.
We certainly can go and approach them. I have to tell you, Darryl and I have been working on this, and as he said, he got information at 6 o'clock tonight. It's very frustrating and hard to get current information prior to this. We were all thrown for a loop on the sprinkler.
Does the disaster car, disaster unit fall under the county's jurisdiction then? I mean, do the commissioners?
Ultimately, yes, that's
So-
Ken would know.
To answer that, and Ken can describe it further, but the way state describes ambulance service or emergency ambulance service throughout the state, they give the responsibility, the state gives the responsibility to the county commissioners to award areas within the county where an ambulance group is responsible. In Lake County, there are 3 areas that the county commissioners have awarded that ambulance service area, or ASA. And so the commissioners are ultimately responsible for delivering the service in the county. They arrange for other people to deliver it, but that's the process.
Yeah, same with wellness or public health or anything. The county is responsible, but we can contract it or delegate it out to somebody else, which happened back in the late 90s.
Is there any tax base collected specifically for disaster unit?
Not that I know of. Do you know, Dan, any tax base?
Not right now, but I know North Lake's going for theirs. They're trying to get that to the voters. But currently, no, we're all not tax-based. Well, we're not tax-based, but Silver Lake Ambulance, which is part of the fire district, the fire part is tax-based, but the ambulance is not. And there's some rules on keeping that separate.
So the 3 areas of ambulance service area is this area, Paisley, and Norway. There are 3 different areas.
Does this area include Warner Valley?
Yes.
Warner Valley's a sub of Lakeview Disaster Unit, because we're the, Lakeview Disaster is the mothership of Warner Valley.
As far as the Bay Area for capacity, how many ambulances do we have? How much vacancy would we have after?
Well, we can fill those bays right now.
Yeah.
We cut bays to save cost. I think Darryl designed it so we can expand both on bays and living quarters if we need to. Right now, we just cut down to what works today because of the cost. So, and we still plan on using the bays uptown as well for additional ambulance. I can't remember how many ambulances we're up to because we've gained a bunch. Because we have a minimum of 2 ambulances and a rescue up in Adel and Plush right now. I think we're 3 in town right now.
Yeah, the reason I ask it is, I maybe down the road, if we have an ambulance that could do some services other than just respond. Like transport.
Transport.
That's been a discussion for a long time. And when we originally started this discussion, we thought we could do a building with 6 bays. And if the Lakeview Disaster Unit did not want to get into the transportation business, then we would have the health district use 2 of the bays, farthest away from where the population, where the crew were, as we would lease that or use that ourselves, and then use that as a transportation business. We just can't, I mean, you can see we're already struggling with costs.
So if we have to do a transport in Lake County from the hospital to Clinton, and it's not flying them, does the ambulance do that? Transport?
On an occasion, they would do it if they can arrange their staff, because they need to worry about having staff in county and available if there's an actual emergency. So on occasion, they do it,
So what do we do?
but it's
if we have to do a
relatively
transport?
rare.
Where do we do most of it?
We don't really have a ground option. So most
So
people
is
go
there-
by air.
Even if it's not time critical?
Well, unfortunately, those people often travel with their family.
It's a difficult situation.
So what it looks like we're looking at is either borrowing more or reducing something in the district's budget. That's the options that I see that we have now today.
I can add a little bit there.
Okay, go ahead, Darrell.
If I may. You were right, of course, we tried to get this into the budget. We worked really hard to get this into 1.3 million. The bids came in at 1.2. It was said we decided in the middle to hard bid this job instead of going with a CMGC contract like the clinics and the nursing home.
Cost plus?
CMGC is you select the contractor before the design's done. So the contractor kind of helps manage the project, put the estimates together. They work good in some projects. I've used them a lot in seismic retrofits in schools and things where you don't know what's behind the wall, because you have ways to handle the costs and not have change orders all the time. Where we have a clean site out here, we kind of changed in the middle and thought if we hard bid this, it's a little more work for us, but we think we'll get a better price. And from other people I've talked to, I think we've saved $100,000 doing it that way, other than not doing it a hard bid. When we did the initial code analysis and talking to the people at the plan review and whatnot, we separated the areas out. An ambulance building does not fit anywhere in the code. It's kind of like an auto repair shop and a business office and residential where the sleeping areas are. So, short matters, they came back with that sprinkler requirement. That is not a sprinkler system like in the hospital. It's a residential sprinkler system. It's got PVC pipe. It's not cheap. It's a lot cheaper.
Is it just in the sleeping areas?
No, they went to a commentary on the code, which was a footnote of the footnotes, and said we interpret that to mean the whole building. So that is the whole building. Like Daniel said, we thought of appealing that. I talked to some other people, and we thought it probably wasn't worth the effort to do that. We ended up probably spending more money putting the sprinkler in. The contractor did get 2 sub bids, so I know he did work at getting a reasonable cost for that. There's some water supply things and things on there. I went ahead and authorized the water line work and stuff already. probably shouldn't have done that, but I didn't want to dig up the pavement again. So if we drop this option, we could put storage up in the sleeping areas. We couldn't have a sleeping area up here. So that would be one option. We could put it in later. I would want to put in all the underground in at this time, so we didn't have to do that again. The window thing was a minor, there wasn't any cost for that. They just wanted the windows bigger and as people could get out of the sleeping room. It's odd, it's okay for them to fall from the window and break their leg on the ground. We don't have to supply any fire escapes or anything, but just so they can get out of the way. Anyway, I recommend we do that. That would be, the building would be basically done if there's some way you can finance that. The light poles, as Charlie said, probably need those. Those were not in the contract, so the contractor did not bid on those because we were trying to keep the prices back as much as we could. Same way with the generator. It was not in the construction contract. So the building needs a generator, but it's that added cost. So we can cut back on that a little bit probably. Right now that generator runs everything, and there's room for expansion at that price. We could cut back and just have like the door circuits, some of the light circuits, nothing else run on the generator. We could cut that back. But we'd probably spend some additional money.
Would there be any merit when you're talking about grants and stuff to equipment? We have grants that if we push back the disaster unit and see if they can come up with the generators through grants, or if that would be an easier outfit.
Do they ever surplus generators, Daniel?
Oh, we get surplus generators, but they're pretty ancient. The stuff we've gotten over the years at SAR, it's just, you spend more on maintenance than you do in that work.
And have we talked to the county commissioners all about helping us and working with?
I have not.
permitting
They've been pretty
Red Rock and
reluctant
some
to
of these other
provide
places where they have leverage?
They've been historically pretty reluctant to provide any kind of financial assistance.
But
And
they also-
unfortunately, this is something that is statewide for rural areas. We are not in this alone. As you go around the state, they're facing similar situations. And at some point, I hope the state addresses this, because those people are traveling in our areas and they're gonna want somebody there trained right away. It's a statewide issue, not just for us, but the burden
That's why
voluntarily now falls on us.
Yeah, that's why I believe that Red Rock and the solar, because I heard some story from someplace that a similar plant was built in a town, at one end of the town, had an explosion, took out half the town. So we need to have something where we can transport and deal with catastrophic events, because we have the capability of having them. And then, of course, I believe that also the solar, they don't tell people what all the little solar goodies are made out of, but I've heard that you can't use the land once those solar cells are all put up, because they're toxic, basically. And so if they're toxic, there's another chance for catastrophic events. And I think that they should be putting money into our community to help make sure that these things don't happen, or if they do happen, that we're ready for them.
On the question first.
So Charlie, what do you need from the board tonight to keep the ball rolling and to move forward? Maybe the same question is for Darrell.
Well, I believe what we need to have you do is, as a minimum, approve the sprinkler system, the basic telecom. Darrell's got some extra engineering costs in there that were not part of his contract, but he has done the work on sizing the generators and getting the sprinkler system set up. As a minimum, I'd like you to approve us
That's
spend
the 116,941.
Yes, yeah.
that additional amount. Now, the other $91,000, we believe it has to be done, whether it's done this fiscal year or we wait until July next year, next fiscal year. Either way, we believe it needs to be done. We wouldn't recommend it otherwise. But we could conceive, and Darrell, correct me if I'm wrong, we could conceivably put that off for essentially 6 months. Is that true?
The poles and the generator?
Yes, backup generator and exterior light poles
Yes,
for next budget year.
I would probably put some conduits in now,
Yeah.
so we didn't
Yeah.
have to cut up the concrete around the
Right.
building.
I
Sure.
mean, there's some things that we could do,
Yeah.
and it may not be a complete reduction of $91,000, bringing it to $1,004,000. But,
But if I understand what you said earlier, though, this will in turn eventually get passed down to the disaster unit as an increased rent.
Correct.
that's correct. I like your idea of approaching Red Rocks. I haven't done that yet, or the solar group. And I didn't talk to the bank about borrowing, but as Cheryl said, there are other sources in terms of borrowing money that we could approach. We'd have to get bank approval.
So, yeah.
Has anybody ever approached the pipeline for anything?
Ruby
other-
pipeline?
Yeah, other than them paying their rent or whatever they pay.
So the company that built the Ruby pipeline has been trading hands, I think, twice. Now, there is talk about if the plant on the coast at Coos Bay goes into effect, then there's a possibility that they would put in a second pipeline from Wyoming all the way out to Coos Bay. That would be a huge benefit to Lake County. Because they already have the right-of-ways. They would just add another series of things. But we have not talked, I have not talked to the current owners of that pipeline.
But I think there's no value in a half-built building. We have to finish this, but I think, Charlie, you've got to come back to the board with, if we approve the 116, how do we bridge the gap? Is it through private funding, through banks? I mean,
We have to come up with that. And I'm not prepared
Or
to say,
budget cuts from other.
or budget cuts, or we would just
Other
simply not do
capital
other things in this fiscal year.
Yeah.
Tough to do, but we would make that happen. I believe you're right, that a half-built building is useful to know.
and we can't start collecting rent on it, they can't use it, there's no way in it.
Kind of move forward quickly. Yeah.
You know, I feel terrible that we've got essentially a 20% increase in the cost. It's not what we were planning on. I heard you loud and clear when the prior board said, this is a cap, we're not paying any more.
And I think we have to go back to whoever's running the disaster unit with these bottom items and say, we may need to work together on these. Which,
You're hearing what the board's saying.
Right.
Yeah, we're in it together, it's for
We are.
our
I mean, we're not,
benefit of everyone.
this is a community benefit built. Our community needs it. It will help our disaster unit provide better service.
no, I agree with Gerald. We don't like it, but we have to put sprinklers in, we have to finish the building. But I don't think tonight we approve generators or lights, and I think we have to get an answer of how we're gonna bridge the funding gap.
Okay? So I would request that, based on that, that you approve the items, the 117,000. And it'll be maybe a little bit more, because as Darrell said, there's still going to be some conduit and some support for being prepared for the external lights and for the backup generators. But
We have a grant writer, don't we?
Yes. Nikki Ellison.
Chris,
Christie, I'm sorry, Christie.
Has she written big grants or just little ones?
So writing grants is applying, getting them is another thing.
Yeah, I know.
And so
Qualifying.
she has looked at lots of things. We have her plate full. And I'll talk a little bit about some of the other things that she's working on. But absolutely, if we can find money some other place. we
Well,
would
Collins
be-
McDonald sometimes will give money too.
It's my understanding that the disaster unit
They already
has
tapped
approached
in.
them to help reduce the $250,000 that they're wanting to put. It's, we're all in this, we're all looking for money.
Yeah.
Charlie, we've given you several different things to come back to us with after you've found some of these answers, but tonight I'd like a motion from the board to approve the regular requirement based in telecom and engineering and the amount of $116,941.
And you needed a little extra just for the preparatory conduits and stuff.
I'm expecting that while we pull out, Darrell, isn't this correct? We were talking about this just a little bit ago. In the exterior lighting and the backup generator, there is going to be a cost to put conduit there. How much of that, I don't know. We have not asked them if we pulled it out. Any idea?
Well, I would only put conduit for the exterior lighting anywhere it goes under a paved or concrete surface.
Right.
I wouldn't put it anywhere else on the
Yeah.
site.
Well, you can put it in the building before you close out the walls, though.
Yeah, we'd have to run the conduit for the generator tie-ins and whatnot, so under the sidewalk areas. I don't know. I'd throw $5,000 in.
So that essentially makes it
Under
122,000.
Well, I agree with it, but I still think Charlie has to come back to the board with a plan of, is it going to be budget cuts, is it going to be outside financing? We can't approve money that isn't there and isn't planned for, and we have to have a plan, because the bills have to get paid, and we're looking at a gap here, we have to plan out how that gap's going to get filled.
Right. As a minimum, what we would do is not do other projects. Other things that have to be done.
That we're in a capital budget.
That we're in a capital budget.
We'll have to go through that and figure out.
Right, but I guess I'm saying that I agree with that, but that's where we got to get back with them also.
Absolutely.
Yes. Alternative sources.
Yeah, how are we going to bridge the financing gap? That would we have to understand.
And we're gathering the information as quickly as we can. Because what we can't do is let Kinsman get stuck and get some stuff done and the project's moving along. They have not gotten approval for the sprinkler system. They've got to.
So the other thing you mentioned is, what if we don't get this done by the end of the year? I mean, are we on target to get it, Gerald, will be done by the end of the year?
Building plans have been, or the steel building plans that come from the manufacturer have been turned around more quickly than we anticipated. I've approved them, sent them on to building codes. I don't have an update on his schedule. I would think that probably right now with the schedule we've talked about and with accelerated on delivering the building, I would say it's still gonna go into January.
We have to get answers from our bond people.
And I've asked, we've had lots of correspondence back and forth. Still don't have a clear answer. What it would cost to do.
I guess the big item is of course the sprinkler. Those are sleeping rooms up there, which is part of the reason for the Hamilton's building, for their space and to have people sleeping there.
Well, that makes sense.
It takes a while to get the drawings back. We're basically operating right now without a building permit. Building codes have been working with me, working with us, because they understand the situation there with the budget. But we need to get back with them on the sprinkler system so we can finalize the building permit and get that done. So That's really the important item. The base and telecom comes later. That wasn't in the construction contract either. That's the hospital's vendor. And they wanted, of course, everything to match on the phones, alarm system, everything be compatible with the hospital alarm system. So that's been a separate cost all along.
And we had to make adjustments when we started building the Lakeview Gardens. Originally, it was in the electrician's portion of the country, and we discovered they failed to put many things in that basic telecom needed to have in to make the right door locks work, and badging system work. And so we just said, we're not going to do this again, because it was a start and stop issue.
The worst case scenario would come out of other capital expense for the district. Everything else failing.
Right, or we could find bank financing.
Yes.
Cash
Or
flow to the rent.
grants, Red Rock, all those other things we've discussed.
So I guess I so move, was it 122,000 we would like to see approved? So I would move that we approve $122,000 for the sprinklers, basic telecom, and engineering.
Okay, do we hear a second?
One second.
Moved and seconded. All those in favor signify by saying aye.
Aye.
Aye. Opposed?
Thank you.
Item number 8, O&A contract approval. Sorry.
Okay. We negotiate, O&A stands, thank you, Harold, thank you.
Thank you for coming.
Yep.
We'll be in touch with you, Daniel.
Sounds good.
I know.
So O&A stands for Oregon Nurses Association. We have two unions here. One is the Teamsters, and then the Oregon Nurses Association. The Oregon Nurses Association represents nurses in the acute side, home health and hospice, and they have for the 30 years that we've had an O&A contract,
But this is just RNs, not CNAs.
just our CNAs are in the Teamsters. And it did include the Lakeview Gardens. We negotiated, we started, the contract was due on June 30. The old contract ended, and a new one would start July 1. We negotiated, we came to a standstill back in March, I believe it was, with a redo to finish up in May. We didn't get it all approved. We got finished negotiating. And the Oregon Nurses Association met and ratified it this July. So it has been ratified by the hospital and home health and hospice nurses. There was a problem with the Lakeview Gardens. And it's a bit of a technical issue. It's not really, we have a hard time understanding why the Oregon Nurses Association wanted to have two agreements. Teamsters agreed to have one agreement for the hospital, home health and hospice clinics, and Lakeview Gardens. Oregon Nurses Association did not choose that. So they now have supplied me today with the final agreement of the Oregon Nurses Association for the acute side and the home health and hospice. They have one with minor modifications for the Lakeview Gardens. The Lakeview Gardens nurses have not yet voted on it. So,
How many nurses are there?
under 5. So it is, I think, a perfunctory vote. I think they will accept the agreement, but it has not been done yet. So what I would ask is we negotiated as appropriately as we could. The nurses have agreed to this. So what I want to do is ask you to approve the Oregon Nurses Association. I did not send a copy out to you. If you'd like to go over the details of that in executive session, I'll be happy to provide that information to you. It's not something we can discuss in open session. But be assured that we negotiated as aggressively as we felt appropriate, but we also don't want to make it so difficult that we have an unhealthy relationship with the nurses. And if you are too aggressive, it's a 3-year agreement, it makes it difficult to recruit. And you certainly feel the brunt of it when you go back to renegotiate in the next period. So it's in both parties' best interest to come to an amicable decision. I think we have done that. So I would ask that you approve the Oregon Nurses Association for Lake Hill District, and once it is approved and ratified by the nurses in Lakeview Gardens, you will give me the authorization to sign that agreement also.
So Charlie, once this is ratified, then it is good for 3 years?
That's correct. And the rates all change over the 3-year time period, all of the components. We have been doing 3-year successive agreements for at least 20 years. Dave?
Maybe less than 50.
Okay, so at least 15 years, or 14. Less than 15.
And it's at rates that we can recruit with and not have.
We believe that it is a reasonable.
Any other questions for Charlie from that portion of the agenda? Okay, then I would entertain a motion to approve. Okay, been moved that we accept the approval of the OMA contract. Second, those in favor, signify by saying aye.
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 And thank you. You understand it's 2 agreements, and I'm authorized to execute both. Well, this is already, the first one has been already ratified, once the other is ratified by the Lakeview Gardens nurses.
Yeah, but they pay the same rate.
That's correct. What makes it an anomaly is the way we supply staff to Lakeview Gardens is they are what are called leased employees. And the reason what that means is everybody is paid by the health district, and then the cost is assigned to Lakeview Gardens.
So even though they work there, their check says
Lake Health District, yes. The reason we did that is cost of the retirement plan. To set up a similar retirement, have 2 plans for a relatively small number of people in Lakeview Gardens would have been cost prohibitive. Would have been a minimum $50,000 to set that up. And it just didn't make sense because they're complicated.
Okay.
Medical staff update.
Sorry, Dr. Hussey is not able to be here tonight, but we did not have any credentialing information or information for
Okay, then I'd ask for Teresa to give us a nurses report.
Well, I have unfortunately not great news about staffing in acute due to the changes that have come about over the last few months. We've had a lot of FEMLA, a lot of people out on medical leave, and there were changes in surgery which resulted in 2 nurses from acute moving into surgery. So we actually have 6 open positions in acute, which we haven't had that in a very long time. So we're working hard to make accommodations for that, but we have 2 KCC graduates that have applied and been interviewed to come on board, but that's 2 of the 6, so we're still working on
So when you
other
post
options.
an opening for an RN, do you get much response of interest?
I get a little bit. And the problem is that there's more positions than there are nurses in Oregon. So it used to be a few years back, maybe 4+ years back, there were a lot of hospitals, especially in the metropolitan areas of Oregon and California, that were not hiring new grads. And so we got a lot of applications at that time. But that seems to have changed. which is the whole point of our growing our own approach.
So when you have someone that is looking at the job, what is the main reason you see that they choose not to?
Not to come?
Yeah.
There's two reasons generally. One is, it's only a certain type of person that wants to live in Lakeview. And people either love it or don't. And you have to find that person that really wants to be here. The other thing that's different about us is that our nurses are generalists. Rural nurses have to be able to do a lot of things, and we require that they not only be able to care for patients on the floor, but that they work in the emergency room and deliver babies. And that's a big, long stretch that some nurses don't feel comfortable with. Also, we don't have doctors in-house. So some nurses from metropolitan areas are not used to that.
What does that mean?
They're used to having a doctor in-house, either in the ER or within the hospital facility, so they never are functioning all alone.
Oh.
Our nurses are functioning alone without a doctor in-house. So those are things that some people find scary. And some of us think it's fun.
But it's not wages.
It's not, I don't think it's particularly wages. It kind of depends on where you're at in the contract. So we've been at the end of our contract, which means some people were a little bit ahead of us. But I don't think it's going to be a big deal once this new contract comes into effect.
But one of the biggest thing is supply and demand.
Right,
Yeah.
that's the biggest issue, is supply and demand. The second thing I had to talk about was, actually for a couple of years, it's been on my goals to develop a cardiac rehab program. And so hopefully you'll see that in the next few months. As we transitioned over to the new cardiac monitoring system, we also had installed a cardiac monitoring system in what is the pulmonary rehab gym, so we can use that gym to do cardiac rehab. And I'm finishing up ordering some of the other pieces of equipment that we need, and then I'll be posting positions for people so we can start the program.
What kind of person would be eligible for cardiac rehab?
In terms of patients, generally people who have had some sort of cardiac event. So they've had a heart attack, they've had angioplasty, or they've had bypass surgery. So those people, and we do get referrals or attempted referrals from the cardiologists in our surrounding areas. So they're referring people back to our community and probably to the MODOC community to have cardiac rehab, but there hasn't been any for them to refer to. So our community has gone without that. So Medicare approves 36 sessions, which are 3 days a week, so 12 weeks of monitored exercise. And in addition to that, there's lifestyle modification classes and education, so people can hopefully stop smoking or lose weight or learn to exercise regularly, or the things that help reduce your risk for cardiac rehab, or for cardiac events.
So there would have to be somebody staffed to run this then?
Mm-hmm. I imagine it to be a part-time nursing position, accompanied by a physical therapist or exercise physiologist who works even less than part-time. So that's my vision right now. And then lastly, sounds like Cheryl's on my same bandwagon, but I have two nurses, speaking of being unable to recruit, I have two nurses right now who are unable to find childcare. And one of them is already moving, has applied to move off of acute because she doesn't have childcare. And I have a second one who's pregnant who does not know how she will accommodate her children. So for the last couple years, I know I've been kind of hammering on Charlie about this issue. It's a big issue for us because we're predominantly women. And it's difficult. It's difficult for nursing mothers
and it's difficult for mothers who have children, especially children who have not been potty trained. So we work odd hours, so even if there is childcare, it's not necessarily accommodating to our hours, and our weekends and our night shifts and all of those things. So I guess I would say that in terms of recruitment, I think one of the biggest things that we could do for our recruitment, it would be childcare.
Thank you, Teresa.
Uh-huh.
Any questions from the board for Teresa?
And daycare has always been,
Daycare.
but you alluded to night care also.
I did, although I think that's less of an issue. Usually there's somebody at home to care for the child, but it's those, I mean, we work 5:45 in the morning till 6:15 at night. So if you have to be at work that early, that piece is really hard, or that late getting off time is difficult.
Thank you, Teresa.
Thank you.
Charlie, CEO report.
So typically what I do is to try and lump a bunch of things together so that it makes it, some of it is, we don't have as much discussion in my portion of the report. So for example, we're scheduled to have, we get audited, not every department, but different components of our organization get audited by the state on a regular basis. Sometimes it's every year, sometimes it's every other year, sometimes it's more than that. We are presently waiting to be audited by the state for long-term care. They were going to be coming out, we expected them either in July or in August. They still haven't shown up. We don't know when they'll show up, but we anticipate that they will be here soon. We do know that the mental health service that we call our wellness service, that team was to be here in August. They had it all scheduled, except they forgot to check about hotels. And so they discovered that no hotels were available, and they rescheduled that for September 18th. Go figure.
They were trying to come around Labor Day.
Yes, they were. We go.
They didn't quite understand what happens in Lake County during that last part of August. So right now we're scheduled for that time. We have had, as part of our Lakeview Gardens construction, while the project is completed, there have been some work that has to take place, either warranty or just issues that have come. Last year, we ran into a problem where we had an odd situation where we had internal walls, pipes freezing. And we couldn't figure out what was causing that. Well, today, the architect came and got up in the attic with our team and found out what the problem was. And what they found was that the contractor didn't tent the pipes the way it was meant to. So what that means is pipes down the center of in the attic. There's insulation on the top to keep the cold air from getting there. And then they put a tent so that the air can come up from below, because the air heat rises, and keep the pipes warm. What had happened is they blew in insulation underneath, and the heat couldn't get to the pipes. So now we'll be meeting with the contractor to come in and remove that insulation from underneath the pipes, put the proper tenting in, and fix that all before it starts getting consistently.
They have bonding or something then.
They do. This is all under warranty, and so they will be doing it. But we struggled with that issue this past year, and you can imagine someone who is in Lakeview Gardens, long-term care and assisted living, where all of a sudden they frozen pipes inside. Didn't make a lot of sense. But we have that, as of today, a plan for dealing with it. It's part of our relationship with our Medicaid contractor. So remember, the Medicaid in the state of Oregon all transferred into what's called a CCO, Coordinated Care Organization. In Eastern Oregon, that's their Eastern Oregon CCO, EOCC. As part of that agreement with that ECO, we are involved in what is called a risk arrangement. And so what they'll do is they will pay us 90% of our charges for our costs upfront and withhold 10%. That 10% is considered a risk. If the business doesn't do well, they keep their 10%. If it does well, they give us back that 10%. There's also some incentive dollars in that for both the hospital and for the medical group to try and reduce the amount of utilization. So we don't overutilize surgery, overutilize other kinds of medical services. We received our check from the CCO on August 30th, and that check is in the amount of $468,893.
That's for 1 year.
That is for 1 year. Now, it's about the same amount that we got the year before. So it wasn't as great as we were hoping for, more, as always, but we still have one other component of the risk arrangement, and that is there are metrics that we need to abide by or try to achieve, and we focus a lot on that through our CHIP program and the Community Advisory Council. And that's where we try to get as many kids to get dental sealants. So work through the schools to have the kids do that. Or have the kids have physicals that are acceptable by the state, not necessarily by what our school district allows. Or we manage our diabetic patients in a good fashion. And there's 20 or so of these metrics. We're waiting for those dollars. It has been fairly good money in the past, but we haven't received that money. We don't know what that was. We should hear sometime in September what that is and get the money. So that's kind of a positive thing. We now have an arrangement with the school through the ESD to have nurses in the schools, in each of the schools, 1 day a week. This is the first time in my understanding is in Lee County where we actually have a nurse in the school. They're not school nurses, they're public health nurses in school. That's a really positive thing, because if a child becomes ill or a student has some issue they want to talk to a nurse, this is a great opportunity. We also are having our mental health therapists available as school has been started to help kids in dealing with some of the anxieties or other issues that students might face, family issues, family dynamics. This is all really a great thing for our community. We're really proud of our relationship with ESD to make this happen.
Charlie, what schools? You said all the schools, but what schools?
So it's in Lakeview, and it's in Paisley, and in Plush and Edel, and in North. All the schools.
And Union.
Pardon me?
And Union.
And you, yes. Now, we're working on schedules on when they're going to be. Right now, it's still school's brand new, so there's some things. If a child, for example, has a health condition that needs to have a nurse being aware, and an example would be if a child is diabetic, so they need to be able to know what to do and be able to help care for that, or other kinds of circumstances, whatever medical condition. So it's a really wonderful thing that we're doing with the school district, so student districts. So we're really excited about that. I would like to ask, before you do that, last week, 2 weeks ago, we were visited by the Mayor's Memorial Trust. They came out and did a site survey to see how we are doing. This is something that our grant writer had been working on. We are getting more and more attention from many of the grants, and they came out looked at what we're doing, and they're specifically focusing on housing issues. And so we are actually submitting our application, it has to be done before the end of the day tomorrow, to the Oregon Housing Authority to get some assistance to develop plans for Lakeview and some of the supportive housing issues that we're going to try and do. There's a developer who's interested in partnering with us. So it's a good step. Hopefully we'll get that grant. It's a competitive grant, but the state wants to have communities more involved in housing. Because while housing is important to everyone, it greatly impacts people's health if they don't have a safe place to live.
You mentioned Oregon Housing Authority, Oregon Housing Community Service.
That's it. Thank you.
OHA.
So, sorry to have that perfectly straight. For me, this is going to be kind of a goofy month because next week I will be joining the group to go into Kansas City to learn about CERN. The following week, I'll be here for part of the time, but the week after that, I will be in Washington, D.C. with the Rural Health Advocacy meeting with our legislatures to talk about several of the hospital representatives, hospital CEOs have been going to meet with our national legislators to talk about rural housing, rural health issues. And we find this, we do this in coordination with Washington State Hospital Association and Washington Rural CEOs. So it's a really positive thing for us. Unfortunately, the following week, which is the first week of October, and the night that we would normally have our board meeting, I've been asked to be on the Oregon Rural Health, that's when the Oregon Rural Health Conference is occurring in Bend. And I'm on a panel the next day at 7 in the morning. And I would appreciate if we could move the board meeting from that Thursday night to the night of the 10th, 1 week later, allowing me to sleep before I get up to Bend.
So it's now the third and move it to the 10th?
If that is acceptable, I would appreciate that concession. It doesn't happen very often, but occasionally
Works for me.
something comes up, and I like to sleep a little bit.
Everybody good with that?
Yeah.
Okay.
Thank you very much.
So note, Jen?
I note, I will publicize it. I'm sure Mike will make sure.
I'll be good. I'm leaving, so, but I will publicize it.
And last but certainly not least, of the important items to talk about is we have extended an offer and to a gentleman to become our long-term care nurses. We've been looking for quite some time, and his name is Mark McGowan. It is scheduled right now that he would start in about the third week of September. So he's working on getting his Oregon nursing license. So there'll be a little bit of a delay in that. So, do you have any questions or issues that I can address that you might have? If not,
Executive session?
we do have some issues that we would want to bring up in executive session.
Okay. Okay, so we will have to, who do you want to remain, Charlie?
Board members of the
Okay. So we'll have a 5-minute recess. Come back, doing executive